from LV Prasad Institute, and right now I'm running a hospital, Swanetra Hospital. I am also a professor in NIMS and medical advisor to Eye Bank Society of Rajasthan. With me is my extinguished panel of co-instructors, Dr. Paras Indravadan Mehta. She has been in cornea practice for the last 3 decades in Sameep Eye Hospital at Vadodara, and she also did a cornea fellowship from LV Prasad Eye Institute, Hyderabad. She enjoys complex corneal and surface procedures with lamellar corneal surgery. She is the face behind CSI care rounds, and also she has several publications to her credit. She has presented several numerous papers as publications and also as instruction courses, and presented papers in various international and national societies. She has been honorary medical director at Elmex Eye Bank and Shri Baichand M. Mehta Corneal Transplant Center, Vadodara. She served as the president, Baroda Ophthalmic Society, and a West Zone member of EBI. Apart from this, she is a nature lover. You should look at her wildlife photography exhibitions. You know, if ever you get a chance to visit, she loves traveling and playing table tennis. We have with us a very extremely acknowledged Dr. Sujata Das, again a cornea intersegment surgeon from LV Prasad Eye Institute, Bhubaneswar. She's medical director of Dushtidan Eye Bank and head of LVPI network. She also did a cornea fellowship from LV Prasad Eye Institute and is currently the vice president of Eye Bank Association of India. She has international fellowships to her credit for Germany, Australia, and also a recipient of multiple awards at the AIOC and various national and international levels. We have with us Dr. Srivali Kaza, again a long-term cornea fellow from LV Prasad Eye Institute, and she did her MBBS and MS from RIO GOH Chennai, and she's presently a senior consultant with Shankar Netralaya Chennai for last almost 8 years. We have our fifth co-instructor, Dr. Ishita Agarwal. She has been a clinical research fellow with LV Prasad Institute and currently pursuing her fellowship as long-term cornea intersegment surgeon from CAR campus, LVPI, Hyderabad. So now I start with my first talk of the day is prevention is better than cure, impending perforations, tissue adhesives, and bandage contact lenses. As we all know that corneal perforations are a devastating complication. It's an ocular emergency, and it causes a lot of ocular morbidity in terms of decreasing the vision and also blindness and sometimes loss of eye if they are left alone. There's also a risk of microbial entry into the eye, causing it infective later on, and you know, a lot of retinal complications and future complications. So how do we manage? What are the principles of management of corneal perforations? So first of all, we have to provide the stromal support that is collapsed to form and maintain the anterior chamber so that, you know, the lens iris diaphragm goes back. It helps in wound healing and also preventing any secondary infection that could be there, and thus addressing the cause. You know, we have to help that the perforations do not recur. So when we look at the corneal perforations in general, they could be infectious. We all know it could be bacterial herpes, fungal or parasitic, and it could be non-infectious also. So it's very important to understand that it's an infectious or a non-infectious corneal perforation, and non-infectious needs to be vigorously managed and diagnosed and properly investigated so that, you know, these do not recur, and a lot of times we confuse them, and a lot of times they become infective also later in the course of the disease. So when we have a corneal perforation, we actually have to see whether it's a small perforation or a large perforation. Smaller perforations are usually less than 3 mm, and when we have a small perforation, we can actually do a glue BCL, an AMG, a TNONS. The rest of the instructors would take that in detail, but if it's a larger perforation, we definitely need a patch support graft or a tectonic graft or any kind of a flap. Also, the bandage contact lens here, it's not a normal contact lens, it's a high decay value eta Filicon lens, which has, you know, it kinds of occupies the tear film in between them, and it actually seals. So a very small pinpoint perforations can be actually sealed by a bandage lens, and it provides a support to the stromal tissue, and also can be kept for a few weeks till the cornea heals. And also if we have a bandage contact lens in place, we need to keep the antibiotics on, and also cycloplegics if prescribed. So when we come to other than perforations which are not pinpoint and they need a kind of sealing, then we have tissue adhesives with us. These are the biological adhesives like a fibrin glue, but it doesn't have that tensile strength to hold the perforation. And we also have synthetic compounds like cyanoacrylate glue, and which is currently much in use. So this is how an isoamyl 2 cyanoacrylate glue looks like. It comes, so this is what we require when we are trying to seal a perforation with cyanoacrylate glue. It is bacteriostatic. Its strongest action is against gram-positive like Staph aureus and Streptococcus pneumoniae, which is a very common infectant. It also inhibits collagenolysis, proteolysis, and stromal melting. So apart from a tectonic support, it also is helping the cornea heal, and it inhibits polymorphonucleosides and also inhibits the corneal melt that is going. So probably it is one of the best agents as of now, and we do not require much. We just require Paracane, cyanoacrylate glue, Vexel sponge, and a bandage contact lens to do it. So this is how it acts when we apply cyanoacrylate glue on a dry surface. It rapidly polymerizes, then it forms a bioadhesive addition in between the tissues, or the stromal tissue or the corneal tissue, and it forms a barrier. So the properties of an ideal tissue adhesive which cyanoacrylate glue has, that it's quick acting, it's biocompatible, adequate tensile strength, permeable to metabolites and nutrients, with minimal neovascularization, and easily available and affordable. So they are used in less than 3 mm of corneal perforations and sealing and leaks. And disadvantages of a cyanoacrylate glue: it can cause chronic inflammation. They need to be removed when we realize that there's an epithelialization that has occurred, there's infection which has gone down, because they can cause giant papillary conjunctivitis if it is left for long. It can also cause, if it goes into the anterior chamber, it can cause a task-like reaction or polymerization in the endothelial surface, and thus can have a iridocorneal and iridolenticular adhesion. And microbial keratitis have been reported if the BCL is kept dirty and not changed very frequently, if you have to keep the cyanoacrylate glue for a longer time. So we need to debride the epithelial surface, we have to dry the surface, we have to apply the tissue, and placement of a BCL has to be done. This is how, I'll show you a video. This is, we have injected air, it's a collapsed AC. We try to form as much of the AC as possible and just take out the aqueous so that the surface becomes dry. We debride the epithelium, and here after the surface has become dry, we put the glue, we keep it for a longer time. We can actually remove the iris which is plugging, but a lot of times we have to leave the iris if it's a bigger perforation. There's another video that, there are multiple perforations which have occurred. It is very important to form the anterior chamber. You can go with a 26 gauge needle. You can just push in the air and form the chamber. It's very important that the surface is not, you remove all the aqueous and you make the surface dry, and the air is left behind in the AC, and then you put, as a regular procedure, you put the glue, and after debridement of the surface. So I'll quickly go through a couple of videos. This is again at the limbal area that the perforation has occurred. This, it's sometimes you are able to reposit the iris going through the anterior chamber, and with a iris repositor you can pull back the iris, but a lot of times when you are not able to pull back, you can actually put some glue on top of it and put a bandage contact lens. So this is a desmetocele. If we have an impending perforation, we can actually seal this before it goes on. It is important to release a little bit of aqueous from the anterior chamber so that the desmetocele goes down. You can push it a little, be very gentle and careful so that you don't perforate, and it is easier to put the glue when the desmetocele is not popping out, and so that the BCL and the tissue adhesive doesn't pop out after some time. A lot of times when you have a foreign body, you also have to remove the foreign body, and there could be an impending perforation or a perforation underneath, and you have to actually debride and put a cyanoacrylate glue while cleaning the surface. So I'll just skip to that. So you don't have to put a lot of glue, just a layer of glue is sufficient, and this is now how you should do it, because ultimately it's going to fall off. So there are changing methods of treatment. There's a lot of review of literature which is available for the cyanoacrylate glue, and a very interesting article which led to the formation of cyanoacrylate glue was that they had put nylon sutures way back in 1997 and had put a glue on top of it just so that the glue doesn't fall behind. So with this, I come to the end of my presentation, and now I invite our next speaker for the day, and we have Dr. Sujata Das, who's going to talk on a stitch in time saves 9, amniotic membrane and tenons to the rescue.
Thanks, Swati. Thanks for including in this instruction course. So all of us know by this time what is immune corneal melt. This is thinning of corneal stroma with overlying epithelial defect due to underlying inflammation. So basically the indication for Tenon's patch graft is neurotrophic keratitis, dry eye disease, Sjogren's, cicatrizing conjunctivitis, SJS, MMG, chemical injury, traumatic perforation, PUK, and make sure that there is no infection. It is written healing microbial keratitis. In active infection, it is absolutely contraindicated. So one of the most common indication is dry eye and non-traumatic corneal perforation. It is difficult in dry eye because of the unstable tear film, ocular surface inflammation, and underlying systemic disease. So we have various surgical options. So Swati has already described the first one. I'll be covering the second and third, and rest of the speaker will go to the other choices. So choice of procedure based on size, configuration, and location of the corneal perforation. If it is less than 3 millimeter, we have option either we do tissue adhesive bandage contact lens, and advantage of cyanoacrylate glue is easy to apply and provide good tensile strength, and it can be given in infectious because it has some antibacterial activity. And disadvantage is you have to keep a long time and induces vascularization, and because you are giving bandage contact lens, it needs prophylactic antibiotic for long time. Amniotic membrane, either single layer or multi-layer. Advantage is it restores stromal thickness, and it has anti-inflammatory properties, no issue of rejection. However, it may lead to opacification. Again, you are dependent on amniotic membrane from some eye bank. You don't have an emergency. Those who are not access to eye bank, it is not, of course, it is available now commercially. Then Tenon patch graft, advantage is autologous. You don't have to depend on the eye bank, cost effective, no risk of rejection. However, again, it will lead to opaque. More than 3 millimeter, there are other options. So coming to the first case, is a 52-year lady comes with left eye watering, diminution of vision, pain for 8 years. And both eyes, he has redness, watering, foreign body sensation for last 1 year. She is under treatment for rheumatoid arthritis on methotrexate. She had history of diabetes mellitus, no history of skin rash, fever, or mouth ulcer, no history of primary ocular surgery. So his vision in right eye was 20/20 and left eye was 20/80. So this is right eye. If you see the left eye, that's a perforation, and you can see the DM fold and thinning area. So left eye has immune corneal melt secondary to rheumatoid arthritis with query secondary infection. Left eye we planned for corneal scraping, and of course, because we thought it may not be a fungal infection and it may be just a superadded, we at the same setting we planned for Tenon's patch graft. Depending on the perforation size, maybe you can decide about the Tenon. Don't take any conjunctiva, do proper cleaning up between, like you take the graft for pterygium, you separate from conjunctiva and tenons. So there are different techniques. Either you just stick with the glue and make sure the suture you pass through the normal cornea. This case it was easy because there was no rounding in an unhealthy cornea, and try to bury the knot when you pass the fast cross suture. Otherwise it is very difficult. If you do wait till the second suture, it is difficult to bury sometime. So first one vision is 2200. You can see the OCT photograph, antechamber is formed. We're lucky that there was no organism in the smear, and we started Zymoxid, Gatifloxacin and lubricating drop for both the eyes. Culture also did not grow. So 7th day visit visual acuity was 2030 and 30 days it was 2020. So the right eye, she has dry eye, she has OSDI 15.63, you can see Surmor 1 is 5 millimeter, and corneal staining, conjunctival staining was there, and there's no egress through any ductile. So we started lubricating drop for both eye. Second, again another lady, most of the patients are female because of the immunological disease are more in female. She had right eye diminution of vision for 17 days and both eye redness diminution of vision for 9 to 10 months. She was diagnosed as dry eye with lidohyperkeratopathy, and she had undergone MMG both the eyes, upper and lower lid, 8 months back, and presented with sudden diminution of vision and watering. So she had history of generalized skin rash, loss of nail, hospital admission 22 years back, and diagnosed as Steven-Johnson syndrome. Her right eye vision was 20/60 and left eye was hand movement. This is her left eye. You can see bony dry with severe, this is the right eye. This is the only seeing eye. She had thinning and perforation. So you can see the keratinization. So it was a known case of SJS, and we did the MMG for Tinan spats graft, and she started with steroid and chloramphenicol because of bandage contact lens and lubricant. So again her post-operative 1 month visit is 2030. The third case is a young lady. She complained for diminution vision only for 22 days. She had fever 1 month back. She took paracetamol for that. She did not have any dry mouth, skin rash or oral or genital ulcer. She had comparatively good vision 20/40 and both the eyes were congested. So this is right eye. You can see congestion in both palpebral and bulbar conjunctiva, and this is the perforation in the left eye. So she also underwent patch graft, and she was started steroid in the both eyes and lubricant in both eyes and chloramphenicol in this eye. She was advised for mycoplasma pneumoniae, which comes out to be positive, and this is the post-op photographs. And the other eye, she had dry eye, she underwent punctal plug. So there are 3 case scenarios, which one of them is rheumatoid arthritis, all are female and different age group, and the second one is SJS, and third one is MIRM. So coming to Tinan spats graft, this is a layer of connective tissue rising 2 mm posterior to limbus. Anterior part consists of smooth muscle cell and posterior part is condensation of collagen fibers. Principle how it works, it allows epithelium migration over its surface. It provides volume, and some people say it does not provide, in contrast AMG provides, but it also provides volume and get integrated with the scar. And this is described from Pertokin lamellar keratoplasty from AIMS, where they remove the suture after, you can see this is the gap, they push they do the pocket in crescent knife and put the Tinan's tissue inside that with the glue. They put the suture to anchor, but once the antechamber is formed, they remove the suture. So it's like Tokin lamellar keratoplasty, Tokin Tinan spats graft can be done. And if you compare tissue adhesive, multilayered AMG, Tinan spats graft, the advantage is there's no vascularization, there's no additional cost, there's no dependency on eye bank, volume replacement plus minus, and risk of rejection is no. So complication is no surgeries without any complication. There may be shallow antechamber. Sometimes the graft may retract and displace, and intratinan hemorrhage. One of the patient I showed, there is an intratinan hemorrhage, this one. And it may melt. Again, infection, like amniotic membrane has more chance of infection, I'll say, than Tinan spats graft, and pseudoectasia. So these are some of the case series of Tenon's patch graft, where it is used for HZO and mild keratitis trauma. TPG with, it may be combined with tissue adhesive also, or only TPG also can be. So from Tenon's patch graft, take-home message is a simple and cost-effective, not dependent on eye bank for tissue, autologous nature reduces the risk of rejection. So coming to another case, which is 39-year-old man who came with a redness photophobia for 1.5 month, allergic to reaction to sulfate drugs. So you can see the peripheral scarring, superficial vasculation, this eye has, and this eye has a lid margin keratination with 360 degree scarring and superficial vasculation, BCBH 2000. There is a symblepharon. So it was a known case of SJS. Surmor was 1 in both the eyes. He was on cyclosporine, sodium hyaluronate, and loteprednol. So he come with a central thinning. So left eye we did multilayer amniotic membrane, and anyway the vision was less. So AC were formed with air bubble. So you can see the OCT, the volume replacement. Again, these cross sutures are there. Either the multilayer AMG, either you can make small pieces and pull the grab and put a large AMG above that, or some people take one large one and make folded into itself and do this. So what about multilayer versus single layer? So definitely the multilayer is required. If it is a severe thinning, one layer will not help. So this 42 cases were divided into 3 categories. One is persistent corneal epithelial defect, one is PED with desmatocele, another is PED with corneal perforation smaller than 1 millimeter. So group A took mean healing time took 3.5 weeks. Group B, where multilayer AMT was done, it took 1.5 weeks. So definitely multilayer heals earlier than single layer, and healing defect also heals earlier. So more membrane matrix provide with greater growth factor. So if it is a thinning perforation, definitely multilayer is useful. Similarly, multilayer in the again depending on the size, if it is microperforation, 2 layers, if it is 0.5 to 1.5 millimeter, 3 layers, and more than 1.5 was 4 layers was used. And there is a, shown the success rate decreases as the perforation size increases with poor outcome if the perforation is more than 0.5, for 1.5 or more than 3. Definitely more than 3 you will do either patch graft or tectonic PK. For severe ulceration in sclera, surprised to know that I have not ever used for sclera, but in scleral perforation also multilayer AMG can be used. In other case, we are combined, it's Tenon's fails, then we did a AMG. So this is a carbide. Recently, there is a lot of carbide injury across the country. We also had seen it is increasing. The first presentation, patient underwent AMG, he was doing well. So one eye was, luckily the carbide injury, most of them are unilateral. So this is the presentation. He underwent AMG, he was doing absolutely fine. Then he came one day with perforation, with, and then we did Tenon's graft. Again, Tenon's graft, you can see the Tenon's graft was here, and the perforation next to the Tenon's area. So we did multilayer AMG, again a covering AMG. So you can sometimes, you need to combine from the planning ways, or in case Tenon's fails, then we can do multilayer AMG. Thank you.
Thank you, Sujata, for that excellent presentation and covering a very difficult topic. So now we have our next speaker, Dr. Shivali Kaza, on Ask Not What Is Lost, Work to Preserve What Is Left, Therapeutic Penetrating Keratoplasty.
Yeah, good evening. So going on to the next part, that if all these things have not worked and if the eye is already perforated, then what are we going to do? So thank you for inviting me for this IC, and it's good to be back with friends and discussing among ourselves. So therapeutic keratoplasties account for more than 12 to 28% of overall keratoplasties performed in India, and most common indication is infection. And it has poorer prognosis because of advanced cases are the ones which reach late for this thing, and there is high prevalence of fungal, which continues even after surgery. So indications would be non-healing ulcers or worsening despite maximum medical therapy, impending of frank perforations, large ulcers which are about to involve the limbus, and ulcers which are progressing to endophthalmitis. So the indications out of the things when we look at it, perforated infectious ulcers are the maximum. And the protocol is that we have to do the microbiological evaluation on presentation irrespective of whether it has been done earlier or not. If it's perforation, we still have to try, as my colleagues have pointed out, as Dr. Swati said, to try with cyanoacrylate glue, bandage contact lens, or if it's possible with any other tissue which is available in case a cornea is also not available. And any donor graft, whichever is available, is what we need to use. Here I would like to emphasize that it should not be that you have to wait for a graft which is not good. Usually that is the problem, because I was told by the eye bank once that this is a good tissue so we can't give you because a perforated ulcer was there. But that's not the idea. If it's a perforation, it's an emergency, and whatever tissue, even if it's a good tissue, you are lucky you can use it. But the idea is, even if it's not good, you have to use and do the surgery. The technique primary aim is to remove infection, not for vision. So you have to go ahead with whatever tissue is available. The diseased host cornea is removed and replaced with healthy cornea. Ideally, general anesthesia, because a local anesthesia will cause more intraocular pressure and it would lead to a perforation and more discomfort to the patient because of the timing of the surgery would be more. And a preoperative IV mannitol helps. The instruments, I'll just run through. Most of the people who are doing keratoplasties would already be knowing this. We use speculums which will not give any lid pressure. We have a newer speculum which is associated along with the Flaringa ring, so that once you put the speculum, then already the Flaringa ring is in place. And the Flaringa ring, so when placed separately, gives a good support, especially whenever you don't know what is going to happen. In these ulcers, when you open, you don't know whether the lens is going to get expulsed or you're going to have to do vitrectomy. So in these cases, it's good to have a Flaringa ring. The peritomy is needed whenever you don't know where the ulcer is extending to. So you need to make sure that you are beyond the margin of the infection. For preparation of the host bed, you have to make sure that you have cleared, and to make an anterior chamber entry and to wash out the AC exudates is very important, because from outside it may look like it's a very big infection, but once you wash out the endothelial exudates and the AC exudates, the actual infection on the cornea may be lesser. And the instruments, the right and left corneal scissors, the Vana scissors which is used to cut the smaller parts of the tissue and the ledge. Anterior chamber management becomes important. As far as possible, do not touch the lens. If it is possible, do not go into the posterior chamber. But if that doesn't happen, sometimes everything is getting expelled, so you have to be every time prepared with an anterior vitrectomy. The retrocorneal membranes exudates also may have to be cleared. Always remember to do 2 iridotomies, surgical iridectomies. And for the donor cornea trephination, always make sure that you are having the graft which is prepared. First you do the host bed, because in this case when you are cutting and removing the tissue and the infection, sometimes the size may vary. So once you have done that, to prepare your tissue. And the suturing has to be like what you would do with any optical keratoplasty, but sometimes you cannot maybe make it as radial as possible, but that does not mean you don't give attention to making them radial. So you may have to use 24 in the case of larger grafts. And always make sure that you are making sure that there's no leak, and once you complete, half of the corneal button goes to microbiology, half goes to pathology, and if any endophthalmitis, the vitreous sample also would go. A temporary keratoprosthesis, when used, makes life very much useful in the case of many combined surgeries. So just to see one video, so to show the Flaringa ring, and then once that is done, you are going to go and measure and cut the tissue, and once you have done that, and to remove the adhesions, the retrocorneal membrane, then you start your suturing, and once the suturing is finished, so you make sure that the graft is there's no leak, and that the sutures are as radial as possible. Post-operative management for fungal ulcers, do not start steroids, continue antifungals for 2 weeks. Make sure that there's no reinfection or recurrence, and then do it. Then start the topical steroids. Bacterials, you can start simultaneously. Viral, you have to give the acyclovir tablet long-term. And for acanthamoeba, again, for a few months, again, you may have to still continue the antimicrobial treatment, though you can still start the steroids. Cycloplegics topical anti-glaucoma medication is what is needed. Progressive graft infection, even after 2 weeks of maximum antimicrobial treatment, then repeat the therapeutic keratoplasty. So for the, this is going back. Complications, damage to the iris, lens, poor donor definition, bleeding. Sometimes you can have expulsive hemorrhage. And so you need to deal with the rejection in case it can happen, not just the infection. Outcomes, it's usually poor because the infection can be there can be a recurrence, and then late graft failures are common, but at least if the infection is not there, that should not be a problem, and you will have to do a repeat optical keratoplasty. So the outcomes, the risk factors become more increased whenever there is a large infiltrate size, limbal involvement, and the lens also is removed, and it's a single chamber. For the acanthamoeba, again, long-term treatment is needed. Pythium is a special, needs a special mention because the recurrence rates are high, and timing of what you do is crucial. If it's a perforated ulcer, you glue BCL, you wait, but then if it is going to the sclera, do not wait and take an eccentric graft in this case, but still if you manage, then the outcomes can be good. This is seeing that there's 3 months later, the BCVA is 6/12 in this eccentric graft. So it doesn't mean it has to be an old, it has to be a opaque graft. This is a one-eyed lady who came, and this was the only seeing eye, and an RTA, and so then these were a silicone-filled eyes, and this is the perforation, was not staying with glue BCL. And once we did whatever we could with a silicone oil implant, silicone oil again inside, so then 6 months later, she has a round counting finger, 1 meter, pale disc, silicone oil, but still 1 meter makes all the difference for a wheelchair-bound lady. Sometimes it is preparation, perseverance, patience, prayers. It's like Lagero Munna Bhai. This is a therapeutic which we did for a pythium, and post-op day 2, it looked fine, but then by the time it was day 14, we are seeing recurrence, then again did a second therapeutic, and then months later, after trying to reduce the inflammation, just last week is when I've done an optical PK, ECCA, IOL, and post-op day 6, just before I started for here. This is kind of thing which needs a lot of long-term and prayers, and you need to be ensuring that you are seeing and not letting go. The follow-up is very, very important. This kind of perforation sometimes very strangely can still have, when you send the button, you think nothing is there, but there is gram-positive bacilli and herpes also positive in this particular patient. So there can be perforations like this. After a TABCL, patient lost to follow-up comes, and that was the lens which is there. So actually we could remove the lens if we just used a cotton bud. And then after an PK, after a couple of months, at least maintaining some vision, had to be operated for RD again in this. So this is a lady whom you think that what is going on, we did not know. We did a keratoplasty. Again, that was also negative. So still, when you don't know, wait for 2 weeks, then start steroids. And the last, as I say never. This was PLPR inaccurate in a lady. She mainly came because she was more worried about the cosmetic appearance. She didn't really bother whether the vision was going to come or not. And when we did, that's why we didn't plan for an SFIOL, because it was a poor prognosis eye. We thought, let's see what is the inside and then decide. Lens expelled out. But this is how it looks after 6 weeks. And still in these eyes also, the follow-up is important. She comes back, had stopped treatment for about 3-4 days, and then there was a signs of rejection. Once we finally managed to control the rejection, 4 months after tectonic PK, the BCVA was 6/9 with obviously a specialty contact lens. Take-home points that therapeutic keratoplasty is a crucial surgery. Primary goal is eradicating the infection, timely intervention, You have to apply all your medical, surgical skills, diligent follow-up, compliance to treatment, and may need vision restoring surgeries to be planned later, repeat optical PK along with cataract, glaucoma, and retina surgeries. These are my references, and thank you.
Thank you, Dr. Shivali, because I think it very aptly said, ask not what is lost, what is preserved is what we have to look for. We move on to our next presenter, Dr. Paras Indravadan Mehta. She's going to speak on There's Still Hope, Never Give Up, Tectonic Keratoplasty with Other Surgeries. Dr. Paras, please.
Introduction and good evening, everyone. Uh, I'll be talking to you. My previous speaker has made the subject very simple for me because she has covered it very extensively. So essentially what I've brought in here is a variety of cases where probably sometimes we feel that there are less options available to tackle those cases. So there is still hope, never give up, tectonic keratoplasty with other surgeries. Many clinical situations like large PUK with severe thinning or perforation, desmetocele or extensive fluid infection involving the entire cornea, or with scleral involvement, degeneration with thinning, nutritional or neurotrophic keratitis, early anterior staphyloма formation, etc., may pose dilemma to a clinician for what can be done next. Especially when it is the only salvageable eye, the decision to intervene demands strong conviction, clinical experience, as well as surgical skills to turn around the situation. Sometimes it could be a staged approach to establish globe integrity or eradicate infection or control inflammation as a first stage, followed by more definitive procedure later. Tectonic keratoplasty is a corneal transplant procedure designed to restore the structural integrity, globe integrity of the eye when the cornea is severely thinned, damaged, or perforated. Unlike optical keratoplasty, its primary goal is anatomical repair rather than vision improvement, acting as a patch to stabilize the eye. Often it is considered as an emergency measure to prevent further vision loss and preserve the structure of the eye. So what are the clinical situations? These are the situations wherein a therapeutic or a tectonic keratoplasty would be helpful. If there is a perforation with or without infection, desmetocele, post-trauma, PUKs with melt or perf, corneal thinning or sterile corneal melts, post-pterygium surgery melts, limbal dermoid excision also would need, if there's a lot of thinning, tectonic support, post-cataract surgery, wound infiltrates, chemical injury melts, non-resolving grafts, graft infiltrates, and to manage complications of filtering surgery. So what are the surgical options do we have? This was also covered by previous speakers very well, but here for very large tectonic grafts, maybe we could have either a corneal or a scleral tectonic graft or a corneoscleral graft. It could be full thickness, partial thickness, or a lamellar. It could be elliptical or a banana-shaped crescentic or freehand. Or there may be associated other procedures like tarsorrhaphy, amniotic membrane application, or a tissue adhesive application, or many other procedures like cataract surgery and vitrectomy, etc., etc. So let's look at the cases. This is a case where this patient developed post-pterygium surgery corneoscleral melt. Probably patient was on mitomycin C, so he developed an avascular necrosis with an iris prolapse. So we just ruled out an infection and tried to preserve this globe integrity with the patch graft. The iris abscission was done and the infection was controlled, and this is the clinical picture. And 6 months later, this patient underwent a cataract surgery for visual rehabilitation. So you can salvage the eyes even if it is, melted very strongly. Look at the second case here. This was another case where you can see that there is a large corneal infiltrate with corneal melt. This was again a post-pterygium surgery patient. Likely patient was on topical MMC drops, presented to us with large area of corneoscleral necrosis. This was the scleral part. Look at this and look at this. So the question is, what next? Should we even attempt to salvage the eye, or should we eviscerate? But he had hand movement and presence of good perception of light and accurate projection of rays. So we looked at the possibility of infection along with necrosis of the cornea and sclera. In view of possibility of salvaging the globe integrity, we decided to do a tectonic large corneoscleral graft. To cover such a large area, we needed a whole eyeball, instead of preserved corneoscleral button. The eyeball was sourced from local eye donation and a large corneoscleral graft was fashioned from the whole eyeball. This is a schematic diagram. This was the plan for the surgery as the perforation area was much larger. So you can see that we use larger trephines were used to mark the area on the cornea as well as on the sclera of the donor eyeball. And you can see here that we have almost covered the defect with a very large corneoscleral graft, and the conjunctiva was covered onto the scleral area. So these are the post-operative pictures of the same patient. And eventually he underwent a cataract surgery, and later on he underwent a central optical graft. I don't have those pictures with me currently for this. So the eye was salvaged. Later he underwent a cataract surgery and we could do a central optical graft in that patient. This was another case where this was a case of known rheumatoid arthritis diagnosed almost 1.5 years back, had undergone TABCL procedure a few times earlier. She was a non-compliant patient, initiated on DMARDs, disease-modifying anti-rheumatoid drugs after systemic workup. But she took longer time in coming back for follow-ups, and she came with this kind of a small perforation. So we had no choice, but she had already undergone a TABCL many times earlier. So we went ahead and did explore that area. There was a lot of thinning, but we could put in the iris back, and we did a lamellar patch corneal graft with peritomy, which was performed to cover the peripheral corneal thinning and restore the tectonicity of the globe as the perf was smaller. However, the underlying cornea was very, very thin. You can see that a very well-attached lamellar corneal graft saved the eyeball. So these are the post-op pictures, and eventually she underwent a cataract surgery, and she is on systemic medications since then. This is another example of a peripheral ulcerative keratitis. He presented like this, and we had to do a systemic workup to rule out all the other causes. It turned out to be, he also turned out to have a rheumatoid arthritis. So systemic management was initiated, and the perf enlarged, and the desmetocele enlarged, and it became a perforation kind of a thing. And we had to do a large elliptical graft, like full thickness tectonic graft for him to salvage the globe. Later, this patient can undergo a central corneal graft. So you can definitely achieve a good tectonicity by performing a patch graft. The key here is you have to continue systemic medications for these patients. This is another example of a 56-year-old lady, a known case of keratoconjunctivitis Zika with RA. She developed left eye sudden onset of watering, pain, redness, and photophobia. She was on systemic management but was lost for follow-up for some time. So this was on presentation, as you can see here in this picture. Because this was an autoimmune corneal melt with an iris incarceration, her systemic steroids were stepped up. She received 3 IV methylprednisolone to control the immune-mediated inflammation, and later we intervened to do a small tectonic patch graft. You can compare the previous picture and the picture on the right-hand side, bottom picture, that after giving 3 methylprednisolone, the area looked much better, and the size of the graft which was needed was also smaller. So we did about 5.5 millimeter patch corneal graft to salvage the eye, and she was continued on systemic management. A similar kind of patient, a 32-year-old female. Here we did corneoscleral, the small amount of scleral ledge also was taken because this was very much peripheral, and there was a scleral involvement also. So more or less a similar kind. This was very interesting. A young chap, 21-year-old male patient. He developed an acute conjunctivitis in one eye. He was on topical antibiotic and steroids, and he also used some plant-based products at home. His micro workup revealed presence of fungus and gram-negative bacilli. And despite, I'm in maximum medical management, his infiltrate kept on progressing, but that was more of a surface involvement. So question was, what next? Because I didn't want to do only a therapeutic graft for him. At the same time, I wanted to save the eye. So we went ahead, we decided to do a therapeutic graft, but when I took him on the surgery, I thought maybe I would just remove the corneal layers, layer by layer, and see what is underlying. So the cornea was dissected layer by layer. All the tissues were subjected for histopathological examination. And fortunately, the lower layers were not having any fungal involvement. So we went ahead layer by layer, and eventually, I can run a little faster. So we could do a DALC for this patient, and he did very well post-operatively. Though I would, a word of caution here that we generally do not select DALC for fungal infections because the chances of recurrence would be very high because fungus can penetrate. So tectonic therapeutic graft was planned as the infiltrate was more on the surface. This was done. This was almost 9.5 millimeter graft. You can see that a scleral rim was also there. We continued with antifungal management for few weeks, and this is how we eventually did, and we have almost, more than 8 years follow-up of this patient. He did very well, extremely well. I think one or two more cases, yeah. This is another example where this patient was being followed up for more than some 8-10 years. He had a marginal corneal degeneration, like it was a Tyrion's marginal degeneration with very bad astigmatism. And almost past 2 decades, it was followed up for past 2 decades, presented with watering and dimness of vision in his left eye since past few months. He had a supranasal corneal thinning with superficial vascularization and lipid deposition involving 5 clock hours of the peripheral cornea with extreme ectasia, and visual acuity had gone down to counting finger 1 meter. So the diagnosis was Tyrion's. We went ahead and decided to provide a tectonic support to this area. So a pocket was created into the sclera and into the cornea. I was just praying that I should not perforate this area. This was a very tricky patient, and we didn't have a transparent drape, so we had to use a white, piece of a drape, plastic drape. So we used our marking pen and tried to get the impression of the area which was involved. As you can see here, I am trimming that, and the donor cornea was dissected accordingly. And this was, impaled in such a way that the graft, corneoscleral graft, would fit into that area. And then that was sutured to that area without actually, perforating the cornea. And this was 8 weeks after the surgery, and the globe integrity is well maintained. The corneoscleral graft is merged with the ocular surface, and his visual acuity is BCVA 6/9 from counting finger 1 meter. And maybe probably eventually he would also require a cataract surgery. That time it is going to be a little challenging situation. This is another example, post-cataract surgery wound infections. This patient had infiltrate more on the endothelial side, as you can see here in the slit examination also. And there was an involvement of the sclera, as you can see on the bottom picture, into the upper part, that probably it was under the conjunctival cover also. We did endoscraping and tried to get the information. The microverca revealed presence of GNB, and it grew pseudomonas eventually. You can see that there is a lot of inflammatory membrane into the pupillary area. We went ahead and did a corneal patch graft for this patient. The wound infection was tackled with patch graft and an intracameral antimicrobials. Fortunately, we did not have to remove the IOL, and she responded without explantation of the IOL and posterior segment intervention. This is another example where we used lamellar corneal graft to give a tectonic support after dermoid corneal excision. She had multilobulated dermoid involving cornea and sclera, and this was performed after removing the dermoid. These are the post-operative pictures of the same patient. So to summarize, each case will demand a special surgical plan. Though being tricky to perform, with experience one can learn and refine the art of doing patch grafts. A very rewarding procedure, as one can salvage the globe and can later perform more definitive procedure for vision restoration. Thank you for your kind attention.
Excellent surgeries shown, Dr. Paras. I mean, with a corneal surgeon with such a skillful hand you have, I'm sure only you can deal with this. So we move on to our last presentation of the day, Recent Advances in Innovative Modalities in Corneal Perforation Management by Dr. Ishita Agarwal.
Good evening. Thank you for giving me this opportunity. So my topic is recent advances and innovative modalities in corneal perforation management. There has been an evolution from the olden era of conjunctival and tectonic glamular grafting to cyanoacrylate glue, then fibrin glue, and multi-layered AMGs. to tenons patch graft, and different newer modalities. So there. In literature, there is mention of management of non-traumatic corneal perforation with tectonic drape patch and synovial groove, where the sterile plastic drape is fashioned into a small patch and glued over the perforation. It is a temporary option, and it is used to seal only a small perforation and to maintain the integrity of the wound, and to plan for a penetrating keratoplasty later. There is also mention of treatment of corneal perforations with lenticules from the small incision lenticule extraction surgeries, where a lenticule of more than 100 micrometers is sutured over the perforation with a 10-0 nylon suture and followed up for a year. It was noted that 100% perforation closure was there, and vision improvement and reepithelialization was there in 3 to 4 weeks. Smile lenticules can also be an option. But the latest and the new upcoming frontier, there was a recent article where the anterior lens capsule was used as a biological drape, and it was stuffed in the perforation area, and then TABCL was applied over it, and at 3 months the anterior lens capsule was seen to be completely integrated with the stroma. Also, there is a development of many in situ forming collagen-based hydrogels, which have a collagen type 1, which is cross-linked with PEG-DA DOPA, which is activated by the visible light, and has strong adhesion mechanical properties, and also is excellent keratocyte bioavailability. And it is comparable with the strength of a cyanoacrylate and the bioavailability of a fibrin glue. There is also mention of different hydrogels, which are hydrogels which are promising biomaterials for corneal healing and tissue engineering, because there is a global shortage of donor corneas. So a 3D cross-linked polymer networks with high water content and tunable properties such as biocompatibility, hydrophobicity, biodegradability, transparency, and mechanical support. All these acts as corneal scaffolds. So there are different classification based on polymeric composition, electric charge, configuration, cross-linking, and origin. There is also a systemic review where they have compared all the future sealants which are there based on the high burst pressure tolerance, biocompatibility, on-demand activation, healing support, and no infection transmission risk. But still then the field is actively trying to build a better glue. So they have described all the biodegradable and the biological corneal sealants. So fibrin glue is currently in clinical use, but most of the other corneal sealants like collagen-based, gelatin-based, hyaluronic acid, dextran, albumin are all in experimental phases. The synthetic corneal sealants like only cyanoacrylate glue and PEG sealants are in clinical use. Rest PEG with fibrinogen, hyaluronic acid, DOPA are in different developmental stages. There is one recently Cura gel, which is a biomimetic hydrogel scaffold which is designed to promote corneal regeneration, which has high transparency and mechanical properties, and it is just over the perforated area or over the corneal defect. The hydrogel is placed and it acts as a scaffold and promotes reepithelialization, stromal regeneration, and nerve growth in animal models. And it could serve as a bioengineered corneal substitutes, potentially reducing the reliance on corneal donor corneas. So the take-home message is that early tectonic stabilization is critical and it should be individualized based on the size and etiology. There are different biological patch techniques like TPG, amniotic membrane, smile lenticule, and modified glue strategies are also present. But the future lies in regenerative biomaterials and hydrogel sealant smart injectable biomaterials and bioengineered corneal scaffolds are the emerging innovations. And these technologies aim to combine strong adhesion, biocompatibility, and tissue regeneration. So corneal perforation management is evolving from a simple mechanical sealing towards biologically integrated and regenerative solutions that may ultimately reduce the dependence on donor corneas. Thank you.
Thank you, Dr. Ishita, for a complete wind-up of the corneal perforation series. So I now thank my other extremely distinguished corneal surgeons present here with me, Dr. Sujata Das, Dr. Paras, Dr. Srivalli, Dr. Ishita, and Dr. Uma Sridhar for having a very patient listening to us. Thank you so much, everybody, for joining us for this IC, and see you next year. Bye-bye. Thank you. Let's have a picture. Yeah.
Yeah, sure. So, I guess it was very nice earlier management by Dr. Swati and Dr. Sujata, especially during COVID when we didn't have tissues, and Dr. Paras excellent